know me know that I like to be able to present cases, honestly, just to be able to think out loud with everybody about common things that come up, as Kara was mentioning. So I'm looking forward to this maybe being a chance for us to be able to share our collective experiences about I feel like a pretty common situation that comes up. Just a sec, I'll share my slides. And I'm just setting myself up with the chat to make sure people see it. Okay. Great. So again, thank you everyone for taking the time to listen. Um, my hope for this is to chat a little bit about this secretion management. I've tossed around different terms to use, and I'll share a little bit about secretion, sialorrhea, aspiration. I think I use all three over the course of this slide deck. So we'll want to gather everyone's thoughts kind of through a case that we've had here and just talk about some of the approaches that we took, and really, really looking forward to hearing everyone's thoughts. Feel free to share in the chat. Like I mentioned before, I'll leave ample time for all of us to discuss too. So to start with some background patient information. AT, he's in his 50s. Initial symptoms really look like this question of a neuromuscular problem with ptosis, diplopia, dysarthria. He ended up bouncing around, maybe a story that some people are familiar with too, different providers. He was initially treated for this question of myasthenia gravis based on the symptoms that he had. But then over the next year or so, he started to have a lot of like progression in his symptoms. Ended up getting a repeat EMG where this question of motor neuron disease came up, and ultimately received this diagnosis of Bulbar-Onset ALS. So the palliative care team here got to meet him soon after the official diagnosis. And from the get-go, there was a concern about the excess saliva and the complications that were coming from it. At the same time, he's also having a really, really hard time coping with the diagnosis. This is someone who is incredibly independent. He's a pilot. He enjoys mountain biking, hiking, living down in the South Bay, California. And so it's just a huge, huge change that he was navigating in addition to dealing with these darn secretions. So in these initial visits, we started a few different medicines, amitriptyline, the hope being the anticholinergic effects would help with the saliva, maybe impact the mood as well. Seemed to help. Then the secretions seemed to go from thinner secretions to thicker secretions that he was really choking on. So there's a question about using the papaya enzyme to be able to break up those thicker secretions. Glycopyrrolate was also mentioned, and he has a lot of experience with different medicines. Actually declined it because he was already dealing with constipation, one of his other side effects, one of his other symptoms, and was really concerned about glycopyrrolate specifically and mitricin. So didn't end up using glycopyrrolate. Like I mentioned, had his diagnosis of Bulbar-Onset ALS. Along the way, ended up having a peg placed fairly early, given the ongoing dysphagia that he was dealing with. He ended up with this mixed picture of copious thin secretions, also having thicker secretions, kind of added on to this management. Ended up receiving Botox to the parotid glands, which seems to be pretty helpful, but was still dealing with some of the symptoms on the side. Eventually, atropine drops were added, and throughout this, I mentioned this one event in October, but it happened a few times over this course where he ended up presenting to the emergency room multiple times because he was just constantly choking. And I have this picture of a recumbent bike because he's someone that was dealing with these symptoms as he was walking around. Actually, his limbs are still relatively quite strong, even though the Bulbar symptoms were quite severe. And so the question was coming up about how in the world he was going to be living out the remainder of this illness if he's still able to go about doing some of these activities that he enjoys, but it's dealing with the choking that comes from all of this. His partner described this appearance of a really raw looking tongue because he ended up getting suction and would just constantly be suctioning the saliva even before it developed to a copious amount because he didn't want any saliva in his mouth, always so concerned about the choking that would happen. And he had a few ED visits as a consequence of it. So I'm not going to spend time on this slide, especially with this group. when it comes to the neuroanatomy and neurophysiology. The two things that I wanted to highlight, though, was the multidisciplinary teams, which all of you are familiar with. And at the end of this talk, I'm going to raise the question about your experience, maybe with a newer member of this multidisciplinary team, and just gauge your thoughts on it. And then this idea of timely supportive management, again, not a new concept to this group. Just wanted to think about this idea of timely supportive management in this particular context together. So I mentioned before, like with the title, we call this sialuria, secretions, aspiration. Think of sialuria as like the thin secretions that end up causing excessive drooling. So thin secretions past the lip border. But then, of course, the other complication besides the drooling is the choking that can happen. And I mentioned this concern about thicker secretions too. So as a fellow trying to think about different ways to be able to manage these symptoms, put together this table where I try to break things up by mechanism loosely. This is something that I certainly want to hear from all of you about if there are additional things that you found impactful, things that are on this table, things that are not on this table, because I'm sure there are many things that I'm missing. And to come back to the case that I was presenting, we ended up touching on a few different things, kind of hitting these different mechanisms. We often talk about this idea of a multimodal approach to symptom management. Felt like we were really hitting each of these different modalities. Still, he was presenting to the ED. And the question that was starting to come up among some of the palliative care team members and with the ALS team was, but if we can move forward with some sort of surgical or procedural intervention. And so I want to use this time to talk about the idea of laryngeal diversions and the different things that come up. Again, don't have to spend a lot of time with this group talking about the considerations that go into things like this.
Sorry, Kwame, I don't mean to interject, but if you want to go back, and if it's okay, maybe we can just pause. Are there other things that ideas folks have for this list? I think it's a great list. I think it's a nice resource for all of us to have access to. I'm just wondering if other people have thoughts before we talk more about the procedural options.
The only new thing that I've suggested to a few patients is that SWIC device. It's like that thing that you wear all the time, like under your gums when you close your mouth. It's good for people that aren't talking much, and good for people that have a lot of salivation, like right after meals. But it's like a little foam device, and it connects to like a little suction belt, and you can just kind of sit there with it in your mouth, and it just sort of automatically wicking away the spit most of the time.
Can you put the name of that in the chat? I don't think I'd heard of that.
Yeah,
nice.
cool.
Yeah, same. That's a cool one.
Put a website for that. I just looked that up.
Here I've got
Nuna, do you specifically use it or recommend using it after meals, or can people kind of be sitting around with it all day?
For people that are like all day, you know, but I've had a couple of people that, like several patients who just complain, like, I don't, like most of the time I'm fine. And then every time I eat, it's just like a water hose. So maybe like post meal, if they have like 30 minutes of severe suctioning, they can just chill and watch TV if they don't like or, you know, especially if you've got like a lot of hand weakness and you can't suction yourself, family can just stick it in for you and you just wear it comfortably for a while until they come back and take it out. Oh yeah, Kara found it.
SWIC devices. Thanks, Conrad.
Yeah.
That's cool.
So some people need it.
Very cool.
Some people like it's kind of 50-50. Like some people just don't like the sensation. They don't like find it to work for them. But
do people pay out of pocket for it, or can you get it covered by insurance?
Oh my gosh, this is another like thing I have no
thing.
The VA. We just kind of send them whatever as long as it's not a bad, they get it.
That's a good question. I know things like PureWix, we've got trouble getting covered.
Well, in PureWix, the pumps were back ordered. You could get the little things, but you couldn't get a pump for like a year.
Does it need a prescription, or can they just purchase it from this website? Like,
or
you know, like, how do you do it?
I mean, typically, like it's like most of the respiratory equipment, where the RT group will put in the orders under your name, and like they have a contract directly with the supply company, just like Norco. So they'll put in orders, sign them under your name, and then they'll contract with Norco to do it. But I don't know how it works in like normal insurance world outside of the VA. But I've had patients like occasionally, even with other medical equipment, they'll say, hey, I found this thing. I want to order it out of pocket, but they need a doctor's note saying that that it's, you know, medically okay, even though it's like a direct pay kind of contract. So like I have signed little offhanded scripts and letters for patients who find their own medical suppliers, but not for this device.
Super useful. Thank you. I'm wondering, thank you, Kara, for pausing here, because it's always nice to be able to update this table too. And certainly we'll think about that one. Are there other things that people have tried, even if they're things that are on this list that they're like, oh, like actually do have quite a bit of success with this? I'll share that for me, glycopyrrolate tends to be a go-to. And I met this patient kind of after what seemed like extensive discussions about it. So I didn't bring it up again. So that kind of felt like one here where I was like, oh, well, that's kind of my first line one that was not used before we started talking about other things.
I mean,
I
I
was
don't
curious
care.
if other people have, oh, sorry, Nina.
No, go for it.
We just did radiation for our first patient, and Kaiser had actually never done it here at Kaiser Washington. So it took kind of a group effort, and she is still needing meds, but feels like she's having to suction a lot less and it's just a lot more comfortable. And I was just curious if other people had done it. We had a lot of conversations about how many fractions to use and ended up doing more because her performance status was relatively high. I was just curious to hear if other people had experience and kind of what the outcomes were. It was interesting and beneficial, but not fully. It didn't provide complete relief, but definitely helped.
That's really interesting, Allie. I was going to ask a similar question if anyone, you know, proceeds to radiotherapy or radiation often, because we don't, you know, usually we use glycopyrrolate and then perhaps atropine and scopolamine on top of it, and but then Botox, but we haven't had many patients proceed to
this patient
radiation,
failed Botox and had tried multiple meds, and we worried that about her prognosis. Like, typically, I think the studies, and there's not really data, but there was some recommendation to try Botox again before radiation, but we worried about her prognosis, like, and making her wait 3 months, like 3 months of poor quality didn't make sense for her. So people were willing to try it, and they're really happy that they did it. There was really no side effects. It was easy, and it definitely improved her quality of life. It was cool.
That's really good to know. Like I've discussed it with a few patients, but in looking up the side effects, like before me in the whole institutional memory of our clinic, like all our people could only remember like 1 or 2 patients that had tried it, and they did have the loss of taste and like significant like dry mouth and this and that. So we, you know, we always present like this could happen. Here's like I found like a little ENT paper with some numbers and odds.
She's having she's not eating, she's peg tube fed, so the loss of taste wasn't a risk. And she's having some dry mouth, but preferred that to just the amount of secretions that she had. And they're using like humidified air with her which is helping. Yeah, I don't know. The neurologist I work with was at first pretty reluctant because he felt like nobody here had done it, but the patient's glad that we did it. And I'm just curious as we start to do it more, if there's different
what
ways.
was the dose you said? What dose did you use?
She got 5 fractions.
Okay, just one
dose. Yeah.
Cool.
Yeah, there's some data for even single fraction if people are really not able to get into clinic.
Yeah, it would be interesting to know.
Yeah,
like how many grays of radiation are delivered, because I wonder.
Let me see.
Sounds like you guys got it about right.
So I can put it in the chat once I pull it up.
Yeah, thank you. This exact idea of like being able to bring in other providers, like talk about what this looks like. We had a similar experience that we'll talk about shortly in this case about if things have never been done before, and it seems like there's sparse data about it, then how do we talk about it? We talk about it as a patient first. How do we talk about it as a team?
Yeah.
I
also would be interested in people's experience with like nebulized NAC or acetylcysteine, and if that's something you do frequently. It's something that we've tried a couple times for people who have more thick secretions that are difficult to clear from their lungs, and you know, it's a bit of a pain to set up, and I haven't seen a lot of benefit from it. So I'd be interested if other people have.
Same. Our Palm group doesn't do it anymore. They said they used to try before I came, and now they don't recommend it. It's kind of fallen out of favor because it just didn't do much.
Got it. Yep.
And I see Claudia, your comment in the chat about organic reasons for discomfort, existential with the suctioning. He did express that idea of drowning, and like every time he choked, it just kind of sent him into a spiral again of like, this is it, this is the end of everything. And so was just always had the suction device in his mouth, and his family would be encouraging him to like, okay, to reach for it when he needs it instead of just constantly keeping the mouth dry and raw. Awesome. Thank you all. Yes, please keep adding to the chat, especially additional data that might come up for some of these other interventions. So considerations in this scenario, as we were getting through those different modalities and the questions were coming up, found ourselves starting to ask about what it would look like if surgery of some sort was going to be on the table and how that might sit with this patient. So we talk about this idea of getting a sense of making sure the patient understands kind of what's ahead. And of course, they have pretty good understanding at this point. And then thinking about what the patient's priorities were. Like I mentioned, very independent. He was a pilot, was flying all the time, like still using a recumbent e-bike, dealing with all these symptoms. Being able to maintain some sort of independence was, of course, a big priority. And in thinking down the line too, he shared this idea of life on a trach, kind of a separate conversation that we'll touch on. And he shared that actually something that he would be okay with. He liked the idea of being able to continue to be in his mind and communicate through other means if or when the time came that he was unable to move around on his own. So hearing this stuff early on made us then start to think about kind of illness understanding for ourselves as providers about like what the actual logistics would look like, maybe similar to what Ali was mentioning in thinking about some of these procedural interventions. And for us, it was this idea of total laryngectomy. And of course, his care partner, very insightful and very direct. I really like her approach to like, understanding the medical side of things. Asked us the question, so who's going to be the person that tells us when it's time to go to surgery? And I always found that interesting. I always want to pose to the group how you all think about your personal thresholds to potentially recommend surgery in someone with ALS, especially if there's a possibility of ventilation during the surgery, they may need it afterwards, and maybe depending on the surgery, they may remain ventilated. So obviously a lot of factors to consider here. And I'll share a little bit about how we approach it in this case, but maybe something that food for thought over the course of the rest of this discussion. So I'll use the rest of the time to talk about some of the different laryngeal interventions and a little bit of the data that I found. Like was mentioned before, found it to be kind of sparse literature that I was not familiar with in residency at all. I found this image actually very helpful though in thinking about the variety of options that are available when it comes to this idea. Certainly familiar with the idea of tracheostomies and just thinking about the anatomy and what that looks like, and having a track that's placed and ability to be able to ventilate in this way, of course, incredibly helpful for the patients who choose to proceed with that route. You can see based on the anatomy too, that the risk of aspiration, of course, still remains. We all know this from our experiences too, that things like aspiration pneumonias, especially aspiration from upper airway secretions, would still be there even if somebody is trached, so to speak. But then the question comes up about being able to divert the trachea and the esophagus. So then if there's upper airway secretions, things fall back. Hope is that with a nice procedure, it wouldn't end up in the airway at all, and maybe can reduce that risk of aspiration. So just wanted to share a few things that I've seen. You've likely all seen these studies too. This one out of Mayo Jacksonville back in 2009 took a look over 10 years in the late 90s and early 2000s. They had 15 patients that had bulbar symptoms, and they're recommended for total laryngectomy. But of those 15, only 5 actually went on to have total laryngectomy. A lot of reasons for the other 10 to not go on to do it, mainly patient preferences. There are some that actually unknown why they didn't proceed with it. One of them proceeded for tracheostomy alone, did not go with total laryngectomy. And in this paper, some of the indications that were mentioned for total laryngectomy included this idea of chronic aspiration. And the paper describes the idea of aphonia. And last time that I talked about the term came up, and it was an interesting kind of discussion about aphonia versus someone being anarthric. And I want to spend time talking about that just a little bit. So a couple of tables from the same paper. In the top left, talking about the demographic of those 5 patients who did go on to total laryngectomy. Ages range early 20s, early 60s. They had ALS for around 1 to 4 years before undergoing total laryngectomy. And the common symptoms, again, this dysphagia and this aphonia, I think is right. And on the bottom right, this table talking about some of the perioperative data. The surgery itself with total laryngectomy ranged from like 90 minutes to 3 hours. The hospital stay, generally less than a week. But again, only 5 patients, and one of them did suffer pneumonia that had a much longer hospitalization. And for some of the complications that came up, talk about this idea of granulation tissue that could be there, but the aspiration pneumonia didn't seem to be a huge one. And one idea that was generated too was that perhaps for the population that chooses to go on to tracheostomy long-term, trach and vent long-term, could this be an approach that could be taken to help minimize that risk of aspiration pneumonia in the longer term? And one thing that I learned in fellowship then is, compared to the US and Europe, there are other countries that have much higher rates of this long-term trach and vents. And so this paper looked at patients in Japan. There was another approach to this laryngeal tracheal separation, and they call this one a central part laryngectomy paired with low pressure suctioning. And the idea here is that maybe can help reduce that risk of aspiration pneumonia like I was talking about. And so don't have to go through this entire table, but
sorry, Kwame, quick question. Is that ENT paper with the 5 patients in Mayo, is that the same procedure as what you showed in the diagram where the trachea is diverted to the base of the throat and the 2 tracts are separated, or the total laryngectomy is a different procedure?
Good question. Different procedure. I'll show an image with the,
okay, awesome.
the total laryngectomy for sure. So with this paper, they were looking at this kind of different surgical approach, and they followed up with these patients about 30 months later, looking at rates of aspiration pneumonia and the oral intake that patients were able to receive afterwards, again, separating air away from esophagus, being able to resume oral feeding given the minimal aspiration risk. And again, very small numbers of patients, but the aspiration pneumonia that was seen, there wasn't any. And so patients were able to, 4 out of 6 of these patients were still taking in some food by mouth at the time that they underwent this procedure. I thought an important detail was that their FVCs at the time of the procedure for them was over 50%, and 4 out of 6, the other 2 weren't recorded. Small numbers, and I'm not saying that we need to have wide sweeping practice changes based on these studies, but additional reports come out too. I'm sure this group has seen some of these. And so the question has come up about this idea of illness understanding, and we spent a lot of time talking with patients about it, but then I felt as a clinician for myself too, useful for me to get a sense of what was out there in terms of how to talk to patients about what to expect. And especially for some who may be in a scenario where avoiding an aspiration pneumonia could be a large priority, then maybe a worthwhile consideration. And so for us, it was really helpful to chat with ENT about it. I don't really interact with ENT too much in this context outside of maybe discussions about tracheostomy. And in hearing them talk about their experiences, they shared a bit about how they commonly do procedures like this, removing the voice box, laryngectomy, in patients with head and neck cancers. And so imagine those patients, they've undergone surgeries, radiations, the tissue they're working with is much more friable, and their term was kind of complicated compared to many patients with ALS. And so, of course, with a skilled ENT who's done procedures like this before, they find the patients with ALS to be more routine of a procedure than folks that have the complicated head and neck cancers. And so again, it takes ENTs being comfortable with the procedure to begin with, but it seems like something that one might be comfortable moving forward with. So this is something that, again, we were just kind of putting together, thinking about some of the important considerations of this idea of understanding this medical intervention, the surgical intervention. Our ENT mentioned this idea of learning to breathe through one's neck and kind of the changes that come up there, and that being a learned experience. And given the underlying neuromuscular weakness to begin with, this real possibility of ventilator dependence afterwards. And so an interesting question that comes up is total laryngectomy is a surgery in and of itself. Tracheostomy is a procedure too. Could one pair the procedures at the same time if a provider is nervous about a patient with ALS maybe going under twice for a procedure? The other considerations being able to talk with care partners about troubleshooting and maintaining a stoma and trach, and being able to think about what the care looks like afterwards. Discussions that we all have if we're talking about trach anyway. And the other piece that I thought was important, and honestly, I felt it was beyond my scope and really needs to lean on ENT, is that different ENT surgeons will have different approaches when it comes to this procedure. And so I just shared a couple of them, my understanding that there are many more approaches that they may take. I don't think I'm in a position to be able to tell the surgeons like what approach to take, and it's really going to be learning from them about how they would go about doing a laryngectomy or a tracheal diversion. This image shows a couple of like other approaches that are taken where the trachea is sewed to the surface of the neck here, and this like sling is created, or you have this like blind pouch that happens, and many different approaches to take. My understanding and curiosity from the group, I haven't seen data suggesting that one is quote unquote better than the other in this instance. I think the numbers are still too small, at least for now. But interesting conversations to be able to have with ENT before chatting with the family. And so to come back to that question of when to go to surgery, I was thinking about some of the things that we're thinking about in this case. And this idea of anarthria, I know the Mayo paper mentioned aphonia, really valuable teaching point that learned from Dr. Rossow, one of our ALS providers here, was just how valuable the utterance of sounds is to communication as patients are losing their voice in ALS. And so, of course, an expected side effect of a laryngectomy is that someone lose the ability to speak, or lose the ability to utter sounds. And so that might be okay with some people that maybe have gotten used to eye gaze devices or other means of communication. But for other patients who maybe really rely on the utterances that families and care partners get to know, would be an important thing to think about potentially giving up. This idea of an adequate FVC, of course, and this idea of maximal medical therapy. And we talked about this idea of salivary management and then navigating like extra saliva and drooling. But there's still a question of how many aspiration events does it take before one's personally comfortable with recommending that someone go to surgery. Again, a lot of important considerations to take into account here, but a worthwhile one, interesting one to think about. So I'm coming towards the end. Like I mentioned earlier, the ALS clinics and teams, as you've all experienced, are multidisciplinary. Goal to be incredibly comprehensive, of course, these long days for the patients that are helpful to kind of have a one-stop shop to see everybody. Sometimes palliative care being part of the team or separately referred to. The question that I was asking was then about the use of ENT and the value that they play. Again, tracheostomy may be a common reason to loop in ENT, but especially if someone's dealing with aspirations, allergia, and we're thinking about these different interventions, I wonder if having conversations with ENT earlier on can also be helpful in thinking about, again, the procedures that could be considered, how they would approach it, ways to be able to counsel patients and families about it. In this case, they're able to have an informational chat with the surgeon first, just to hear what their approach would be like, because I think similar to what was mentioned with radiotherapy, we didn't have a ton of patients who had undergone this procedure before either. So patient, along with us, were collecting information about what this would look like and what the experience was for the ENT providers. I was taking a look about this idea of the multidisciplinary team, and there was this described as a case report of kind of some of the benefits of having ENT as part of the ALS team, again, beyond the idea of tracheostomy. And so to me, I remember rotating through those ALS clinics and recognizing from the patient perspective that it ends up being a pretty long day. Not everybody would need to see ENT at every ALS visit, of course. But it's an interesting question about how to access these other valuable team members for a very particular, but of course, very valuable symptom intervention. Think about someone like surgery or I wonder about radon when it comes to the radiotherapy too. So just to summarize, again, with this group, we already know the illness understanding and patient priorities. I think for me, the illness understanding piece was actually more work for me to think about ways to be able to bring ENT and neuro and palliative together to be able to think about whether or not this intervention would work well, the best timing to do it, considerations from the surgery standpoint to be able to optimize that perioperative experience. used to having those provider discussions on the inpatient team because everyone's already there, but being able to help organize that on the outpatient side, I find that to be a pretty important role that I'm playing as a palliative provider. We talked about the multimodal approach to secretion management, and trying to touch on each of those things maybe could be one approach to take and quote unquote maximize medical therapy before thinking about other procedures. And then thinking about who the other team members are. And maybe it's bringing them in earlier, trying to have early conversations with ENT or rad-onc or whoever it might be, and thinking about management of this pretty bad complication of sialorrhea. And I didn't touch on this explicitly, but just to say out loud now, there was a lot of discussion that we had about this idea of laryngectomy first, and then trach and being vented long-term later, given that he was pretty ambulatory, mobile, etc. But at least in this case, there was a lot of concern about the potential quote unquote hit he would take with a surgery like this, and how much weaker he might become. And so a valuable discussion with ENT as well, because depending on the approach they might take when it comes to laryngectomy or some sort of laryngeal diversion, it might inform how routine the trach procedure down the line could be. So interesting conversations that we had. Huge thank you, of course, to everybody, and from the patient, care partner, palliative, neurology, ENT, fellows past and present, respiratory therapy. Really appreciate all of you thinking out loud with me here. And we have quite a bit of time, so we're just curious to hear people's experiences when it comes to looping in other providers. And yeah, thanks again.
That was great, Kwame. Really helpful. I'd love to hear if anyone else has seen this done, what your experiences have been.
I wanted to add a few things. Kwame and I each had a patient. My patient actually declined. She went pretty far down the road towards a total laryngectomy and declined it. And she, number one, she was very active. She was still able to use her arms and legs, and was a retired airline worker, so she would travel a lot. And but she had horrible sialorrhea. But she didn't really want the open stoma at the base of her neck, and then she also really wanted to be DNAR. So the thought of like having this done and then maybe ending up on a ventilator was kind of a deal killer for her, because it wasn't really within her goals of care. But it's really complicated, and it was a big learning curve, and I'm still learning about this. But one thing from what I understand, the total laryngectomy, they can actually still swallow if the food is not too bulky, by just kind of tilting their head back a little bit. And that's really nice for people with ALS. And the other thing, my understanding is, if you have a total laryngectomy, you don't actually need a tracheostomy later, because you already have that stoma. So it's called a laryngectomy stoma, and they would just breathe through that. You would, of course, need a collar to like hook it up to the ventilator, but you don't need a separate like tracheostomy procedure. And then also the total laryngectomy, it is a 1 week hospital stay. So it's a much bigger surgery than a tracheostomy, which is a much shorter hospital stay. So that may factor in for some people as well. And then the different procedures are really complicated, but in talking at the time to our surgeon, he felt that there are some procedures where they can, in theory, reconnect the larynx. And those are a lot of those diversionary procedures that I think were in that Japanese study. I'm not 100% sure, but he said in those procedures, there's a blind pouch that forms in the back of the throat and you can't swallow. But actually the danger of that, like in someone with ALS, where they're not going to regain their ability to speak, the danger of that is like secretions can pool back there, and sometimes that can rupture like a year or two later. So he really felt like a total laryngectomy was the best way to go for the ALS patient. But I don't pretend to be expert in that. That's a pretty complicated discussion, and probably different ENT doctors would have different opinions on that too.
Okay, and this is all presuming that they like would not be eating anymore, period, after the procedure, like no PO intake. or do people still?
Yeah, so
Like
I
moving
think
to
Paul
that?
mentioned this in his patient with this one too that I presented. He does eat a fair amount. Like Paul mentioned, he enjoys like coffee and like the occasional beer, and
Oh,
so
okay,
he'll be
sorry, I
able to
missed
have
that.
it, and with
That's
tilting the
really
head back,
cool. So they can
able
like,
to drop in. Yeah.
that's really cool.
And so this patient's care partner talked about the idea of the theme of ALS being losing things over and over. And this was like the first time where they're able to almost gain something back. And so being able to enjoy tasting something again without the risk of choking on it was something that they really strongly considered. And given that this was kind of a unique scenario where he was still pretty ambulatory, he was able to like take his recumbent e-bike down to his local cafe, like sit around with friends and was able to like enjoy coffee afterwards.
Oh,
Like Paul mentioned, it was like a week-long hospitalization. There was like the
yeah.
trouble with management of the stoma and everything. There was a lot of stress around that period too. And to be able to get something like that back, we just passed ended up having his procedure done in January 2023. So just over a year. I'm still continuing with that approach of enjoying tasting things, now being like use a wheelchair to like go over to the coffee shop and things. So it's kind of a compelling idea to be able to
And
give
he
something
doesn't
back,
eat anymore.
doesn't have the strength to be able to chew, but having a certain consistency to be able to then have his head tilt back and still enjoy the taste and things fall back. The risk of
Okay.
aspiration isn't there. The
And
last thing I want to
doesn't
mention,
speak. I don't know. Is that what you just said, Nuna? Doesn't speak.
Yeah, it's for like patients who like are, you know, they're on their way. Like I have a older guy who would be perfect for this, except that he's like super anti-technology, super like, you know, he's still walking, his breathing is great. He just has terrible bulbar symptoms. And he can still talk. It's just very frustrating. And like you only understand like 10% of what he says. But he's said to me basically like, once I lose speech, like I'm out. Like no, none of this computer stuff. Like no. We've been trying to kind of adjust him to the loss of speech idea. But I think if you were to tell him like, yeah, there's like no chant, no phonation, like your whole voice box is gone, which is what it sounds like would happen, I think he probably wouldn't go for it. So it seems like if you're like your guy was very understanding that speech was going to be a loss, but he could regain all these other things if he did the procedure, which is awesome.
Well,
Yeah, I'm thinking about this case. I was thinking that like just losing the ability to phonate, even if you can't articulate, like just being able to say like, help kind of statement or sound at night, might be a loss to not be able to sort of generate any sound and ability to get attention if people aren't looking at you. Just something to think about.
yeah, something that Laura brought up before that I thought was like a really valuable point, that there's a lot of communication that still happens separate from articulating words. And so, like you mentioned, Nuna, it's a huge trade-off and an important one that I think, yes, like other teams can talk about it, but maybe that's also some of the anticipatory guidance that we can provide as palliative clinicians and thinking about this like procedural or surgical palliative intervention. I feel like that's the biggest learning point for me too, like being able to think very broadly about symptom management, to think about the ways where surgery and interventions like this can be helpful, separate from the meds that I've grown more comfortable with.
Do the surgeons at all mention to you guys like if you don't get trached, like is the bore that you're breathing through, is that like a lot different than your mouth? Is it more resistance? Do you feel more short of breath? Like you mentioned acclimating to breathing through the neck, like kind of what does that feel like?
Good question. I also won't pretend to be an ENT expert. One thing I thought was kind of interesting that I just hadn't thought about before, it talked about the idea of humidifying the air that we breathe through our mouth or through our nose. And that would be a very different experience if one loses the ability to humidify things up here and they're breathing down through here. And so there are some, like Paul mentioned, people might wear collars, and there are other like things that could be used to help humidify the air that's coming in. So that's a bit more comfortable to be able to breathe.
And do you have to block the nose to breathe? Like, do they have to pinch their nose so that they're like not breathing into a blind, or I don't know. I guess if you just breathe into the blind pouch and your neck at the same time.
So I don't recall anything about having to like pinch to be able to take a breath.
I had a question. So I understand that this is a great option for people that are aspirating out of the sialorrhea, but if I'm gathering this correctly, this doesn't actually resolve the problem of sialorrhea. You still have people that now have a total laryngectomy, but with ongoing copious secretions that now are just only able to divert into the esophagus. I wonder if they still have any of those like uncomfortable sensations from the sialorrhea as they go to the esophagus. I didn't know if anybody had insight on that.
I actually
Yeah,
can answer if that's okay.
Sure.
So
Definitely.
actually, there's a study done that suggests in ALS patients, they actually make less secretions than people without ALS. The problem is they just can't swallow. So it's the accumulation of secretions. So this really does resolve that problem because they would just swallow their secretions down in their esophagus, and they've totally separated the trachea and the esophagus. So they're not really going to have, problems with that anymore. So.
I just wanted to highlight a question that Green asked in the chat about why only bulbar ALS, because I think it's a valuable question. Paul, I think we had this conversation before about what if someone has another, let's say, limb onset ALS, they progress to a place where they're bed bound, they're trached, they have their PEG, and they're still at risk of aspiration pneumonia from upper airway secretions. I think there's a fair question to ask if they're an arthritic, they're in this place, could those patients also benefit from total laryngectomy as a way to be able to reduce the risk of aspiration pneumonia from the upper airway secretions? Interesting one that I haven't seen yet. I'm not sure if other providers here have. For patients that are like bedbound, trach, I think for us, a lot of those patients, the question comes up about if they're cared for at home or in an LTAC. Oftentimes, I've had a few cases where patients have decided that after their third, fourth, whatever aspiration pneumonia event and hospitalization, they don't want to continue in that way. If this is a procedure to be able to reduce the risk of that happening, then maybe it could be considered in that population too. A little bit different than what I think is this unique group of like bulbar onset still like walking around.
Yeah, I guess I wonder if like surgical ability, like stability, like from a general perspective of the safety of actually doing the procedure might be the reason that they don't feel comfortable doing it. Like once they get to that stage, their FVCs might be really low and they may not be a good surgical candidate. So I wonder if that, as Paul kind of responded to me, but I was just wondering if, yeah, like, well, I think, yeah, I wonder how, like, where that line is drawn, for example, like how they determine that, or is it just kind of standard pre-op evaluation?
Both Paul and Kwame's patients were pretty well, appearing and very, both of them were like, considering they had ALS, like really still quite active, both of them. So I can see how that would influence a surgeon,
Maybe one question that I have for the group too, just I'll share like personally, I get nervous about someone with ALS going to surgery when they require general anesthesia and the risk of like ventilation during the surgery and the possibility of having to recover from that afterwards. I feel like I'm scarred from events in residency when people come in, they're intubated or something, and they're unable to come off the vent. So of course, this is a different context where we can provide all the counseling ahead of time and have them make an informed decision. Just curious to hear how you all think about this idea of surgery in someone with ALS, and maybe how you think about counseling them one way or another, even if it's separate from total laryngectomy or something specific to the ALS.
Yeah, I remember in this patient, I worried that he was going to have more of a functional setback than he did. So that's kind of interesting. I mean, I think maybe I have to check my own biases around, seeing someone with ALS and just worrying that a surgery might be a lot to put them through. Maybe the case, but may also make a lot of sense in other situations. And, depending on a patient's goals of care and values and priorities.
It's kind of an interesting group of people because we consider like procedures and surgeries is kind of as their standard part of care, unlike other diseases, right? Where like, I don't know, heart failure, not everybody needs a surgery at some point. So I think it's kind of an interesting thing because you're already thinking about that as part of their conversations and kind of assessing. And I think like it's kind of a nice excuse to engage in some goals of care conversations. We think of them as pretty fragile, but they are sometimes so much more robust than we, as Cara was saying. But also definitely like I'm not as, I think I personally find I'm not as like shy about thinking about them, about procedures or surgeries with these individuals compared to like other diseases where like I'm like, I am not the expert in this. I have no idea, what their, risk will be. And then we're assessing things like FVC, and we're actually looking at all these like labs and things like that more routinely, compared to, so things that would inform our decisions, I think, a little bit more routinely. That's all.
I think Umbreen, like the point that you're making is kind of like it's sometimes people get blinded by a single diagnosis, and I feel like ALS, it's especially true. I often see like everyone just like mic drop, and all of a sudden their like chronic complicated pancreatic biliary obstruction thing is like no longer on, that nobody cares about cards anymore. I'm like, guys, he's not dead yet. Like the ALS is going to be like a 5-year process. Like the bigger problem here is a 78-year-old with a geriatric syndrome, and that's going to kill him sooner than the ALS, is the fact that he's had RSV and COVID, and now he's had delirium. And like, can we like not forget about the bigger context of the patient? So I think to your point, like just remembering, that like that guy is probably a terrible surgical candidate. Like every time he comes out of the hospital, is 5 months of delirium. And like, certainly that's the bigger problem, is kind of a geriatric dwindle versus like, a young guy who's pretty functional and has good organs, good baseline, still walking around, still doing stuff,
And actually, it's interesting what I'm remembering some of this conversation. This was about a year ago for me, but with the surgeon, and we did have like a 45-minute conversation with, I did, and I think Kwame did as well. And but he said, he goes, well, gosh, I thought ALS patients had only like months left to live. And he was like, why are we going to do a total laryngectomy if they have months of life left? And I was kind of like, well, this person's prognosis is probably measured in years, probably like 3 to 5 years. And he was like, 3 to 5 years? That was like a big, I'm remembering this now, that was a big driving factor for him to be like, okay, let's do this,
I think of what Ali mentioned about some of the maybe pushback coming from other providers when with radiotherapy, and again, parallels here to the values of us being able to share this information with people that maybe don't see a ton of ALS patients as much as we do, and thinking about whether or not these interventions could be helpful.
Oh, I see.
It's not even sorry, Dana, I was just gonna say, it was actually the neurologist I work with who gave me some pushback, and not in a mean way at all. I had like a lovely relationship with him. He had just never done it. And it was funny for the palliative care person to be the one who felt like I was being more aggressive. But I think recognizing the potential impact on quality of life, even if it's pushing the team a little bit out of their comfort zone, I think is just an important thing to like consider and think about. And sometimes less is more, but I think sometimes more can be better for the
So true.
patients. And I just think we all have like a idea of what we would do for ourselves, what we want for people, but I think sometimes there are options, and sometimes different options. I don't know. This case was just really enlightening for our team, and I'm really glad that it worked, because I think it'll make the team open to thinking outside of the box a little bit for future patients.
It's really great. And it's really interesting. I mean, we've had a sort of collection of those cases where the palliative care team has advocated for more aggressive treatment, so that has ended up feeling like it was consistent with the patient's goals. And it would be interesting to like write a little series of these cases, aggressive palliation. I definitely think that they do come up. It's an important part of what we do.
I think I figured out my source of confusion. I think like when you guys were saying bulbar ALS, I was thinking you meant like bulbar-onset ALS for the longest time, like patients that just start as bulbar and then die in like a year. And I guess it sounds like we're talking about progressive bulbar palsy. kind of where it's typically much more limited to the bulbar reason only for, 3 to 5 years. So I think that makes like total sense to me why that population would be uniquely suited to the procedure. And I'll admit, I have read about these things and I've never offered it to a patient. And it's really cool to see your outcome and like hear the stories with this guy who's like, drinking coffee with friends, and just be aware that with this really amazing kind of coordinated team effort, that's something you could give back to him. So very cool. Thanks for sharing, guys.
It's awesome. And if you don't mind me just putting in a little self-centered plug here, but we have a few minutes and then we can get back to the conversation if people have other comments. But I've been working with a group of people to develop surveys of palliative care clinicians, and then a separate survey of ALS clinicians about their experience sort of providing palliative care to people with ALS, what's working, what's not working, what ideas for improvement they have, and making this care more available. So I just wanted to mention that we're getting close to the final phases of sort of piloting these surveys, and I'm going to send them out to all of you soon. And I would love it if you could circulate it to your interdisciplinary ALS and palliative care teams that you have access to or that you work with, that might read an email from you. That would be really helpful, because we'd love to get a broad sort of learn about this broadly so that we can use it to inform, some of the activities of this working group, and to generally build more services and resources that help promote palliative care for people with ALS. So stay tuned for an email coming soon. If you guys have any questions about that, of course, don't hesitate to reach out. And thank you all very much. But yeah, and Umbrini, you have another?
I have another selfish
PSA?
plug.
Cool.
For the I think a lot of people actually left, but for our organization friends who are on, to fill in that Excel sheet with resources for patients and care partners if you haven't already, although I think a couple of those people have left. So anyway, maybe not relevant. I'll send out a reminder.
That's good though. Thank you for working on that, beating the drum.
Yeah. But for you guys to know that in the coming months, that will be part of our activity, is to ask folks to help us kind of vet and evaluate the resources that exist once I compile it all together. So we'll forget about it until 6 months from now.
Perfect. And so yeah, we look forward to seeing you all the first Thursday of June, and we'll have a strategy exchange conversation. Brita and I have a couple different topics that we're interested in talking about together. So, but as a reminder, we also can have works in progress presentations during these monthly meetings. So if you have a project you're working on, or a project you're just starting to think about that you want input from this group, please let us know. We'd love to hear from you, have different people, highlighted and speaking and presenting during these things. So just let us know if you have a case, if you have a topic that you'd like to just talk about and get people's thoughts on, or if you have a project you'd like input on. And yeah, so Gail just put in the chat, June 6th at 9:30 a.m. Pacific, 12:30 Eastern. Do the calculations for the other time zones. And hope you guys have a wonderful month. Until then.